women. 25% of infertile women who suffer from infertility, whether primary or secondary infertility, they will need to use ovulation inducing agents. These agents uh, will help either the patient to produce or to make to mature, to get a mature ovum within their ovaries, or to help them release the already matured ovum within their ovaries. So there are two factors actually that are related to ovulation inducing agents. First, the maturation, and second is the release of the ovum from their ovaries. So as I mentioned, this can be used for the treatment of infertility, whether primary or secondary infertility. So moving forward to the causes of anovulation, it's important to know the causes, because based on these causes, we are supposed to choose the kind of treatment for each kind of anovulation. So the first cause can be due to hypothalamic hypogonadism, and this will lead to decrease in the releasing hormones that should stimulate the anterior pituitary to produce the gonadotropin, the FSH and the LH. So in hypothalamic hypogonadism, we expect low FSH and LH as a cause of anovulation. The second possible cause, an important one, is also hypopituitarism, or uh, uh, increase or decrease in the production of FSH due to pituitary cause, not due to higher hypothalamic cause. Um, or another common is hyperprolactinemia, and the prolactin, we know that it's a hormone that is produced by the anterior pituitary to have an action on the breast milk production. But the other action of the prolactin is that it causes a negative feedback inhibition of FSH and LH. So it will lead to pituitary reduction of follicular stimulating hormone and luteinizing hormone production. Therefore, any case of hyperprolactinemia, whether due to pituitary adenoma or just a hyperprolactinemia, this will lead eventually to reduction, negative feedback reduction on FSH and LH. Other than the hypothalamic and the pituitary causes, there are also ovarian causes, and the commonest ovarian cause is PCOS, polycystic ovarian syndrome, which can be which can lead to normal gonadotropic anovulation. In the first part we mentioned, in the first cause, there is hypogonadotropic. There is hypogonadotropic anovulation. Here it is normal gonadotropic anovulation. Is there anybody waiting for the in the lobby? Okay, we'll try to get him in. Muhammad Farhan. Okay, admitted. So for the second part, where there are ovarian causes like PCOS, we expect the FSH and LH to be a little bit disturbed, but within the normal range. Like there is an increase in FSH, reduce in LH, but both within the normal range, but the disturbance is in the ratio of the FSH to LH. The other causes can be due to ovarian dysgenesis or gonadal dysgenesis and premature ovarian failure. And here we expect the FSH and LH to be higher than normal, which is we call it hypergonadotrophic anovulation. Hypergonadotrophic anovulation. There are others less common causes, but it can happen also due to thyroid hormone problems, like in hypo or hyperthyroidism. This can affect the FSH and LH level, and it will lead eventually to infertility as a result of anovulation. So the classification by WHO, the classification of WHO of anovulation is according to what I have just mentioned to you. There is hypogonadotrophic anovulation, in which there is either a pituitary or a hypothalamic cause of reduction in the hormones of FSH or LH, or they're releasing hormones from the hypothalamus. The type 2 of anovulation or hypogonadism is normogonadotrophic, and the very prominent example is the polycystic ovarian syndrome, where there is a disturbed ratio of FSH and to LH, but this still it is within the normal range, therefore it is normogonadotrophic. The third type is hypergonadotrophic, where there is an ovarian failure or gonadal dysgenesis. So when there is an ovarian failure or gonadal dysgenesis, there is no treatment for ovulation to take place. In gonadal dysgenesis or ovarian failure, we cannot treat medically. We cannot treat medically the patient infertility. We move forward to the next slide. There is a misconception I need to clear here, that some think that the presence of a regular monthly menstrual bleeding is a sign of ovulation. Actually, this is a misconception, because the menstrual bleeding can be regular for a woman with an ovulation too. Of course, the presence of an irregular menstrual bleeding can be a strong sign of the hormonal disturbance that can lead to an ovulation. But even in the presence of regular menstrual bleeding, um, it cannot be considered as a sign of there is an ovulation, because the menstrual bleeding, as we see from the figure, from the graph, that it is mainly regulated by the rise up of progesterone and estrogen, and then the decline around the days of bleeding, days of menstruation. Uh, while for the ovulation to take place and for the ovum to mature, it needs FSH, and for the ovulation around day 14, it needs an LH surge. It needs the luteinizing hormone surge. So the regular menstrual bleeding is not a sign of the presence of ovulation. So the principle of using ovulation-inducing agent is to stimulate the ovaries to produce single mature dominant ovarian follicle, and then to induce ovulation, so maturation and inducing ovulation, and therefore we are allowing fertilization and pregnancy to take place by the natural intercourse. Okay, we have another student. Huh? Okay, we have another student. We need to admit them. Okay, admit. Akmal, are you still following? Akmal, are you still following? Okay, thank you. So for the approaches, because of there are different types and different causes, so we have to have different approaches. So for example, clomiphene citrate is a drug of choice which is an SERM, and we know that SERM is a selective estrogen receptor modulator. Clomiphene citrate is one of those drugs belonging to selective estrogen receptor modulators that is mainly used for the treatment of normal gonadotrophic anovulation, in which the gonadotrophin are considered to be normal. So we don't need to uh, replace the gonadotrophin themselves. So we use clomiphene citrate. Okay. On the other hand, number two is follicular stimulating hormone and luteinizing hormone analogs. These are used for hypogonadotrophic anovulation, where the FSH and LH are low in their plasma concentration, either due to hypopituitarism or pituitary causes of low FSH, or due to higher hypothalamic cause of decreased releasing hormones, gonadotrophin releasing hormones. We can use aromatase inhibitors, letrozole or letrozole, and these are drugs that inhibit the conversion of androgens into estrogen. And these are also important this can be used for the treatment of normal gonadotrophic hypogonadism or anovulation. The dopamine receptor agonist, number 4, can be used for the treatment of hyperprolactinemia and ovulation due to hyperprolactinemia. And insulin sensitizers like metformin and glitazone are used for the treatment of anovulation due to PCOS, polycystic ovarian syndrome. So this is the approach. This is the approach to restore ovulation based on the cause. And then we have an example of polycystic ovarian syndrome, as I mentioned to you before. It's a common problem, and it's characterized by obesity, hyperandrogenism. The hyperandrogenism means that there is increase in the androgen level in the blood, both due to ovarian increase and also due to adrenal increase in the production of androgen hormones. And this will be associated with anovulation, and of course, anovulation will lead to infertility. So one of the predisposing factors is found to be insulin resistance. Insulin resistance means that the peripheral insulin receptors are becoming more resistant to the action of insulin to allow glucose enter the muscle cells and the adipose tissue. And there is an androgen excess, and this will eventually lead to abnormal gonadotrophin secretion, and there is also a genetic predisposition for that. So as we can see here in the figure, in the pathophysiology part on your left hand side of the screen, there is at the lower part you can see hyperinsulinemia and insulin resistance, and this hyperinsulinemia and insulin resistance will lead to hyperandrogenism, and this hypoandrogenism can lead to increase in the extraglandular aromatization. And aromatization, as we know, is increase in the aromatase activity. Aromatase activity is the conversion of androgen into estrogen, and this will lead to disturbance, in the LH and FSH. There is an increase in LH and there is a decrease in FSH. The ratio is disturbed. Of the gonadotropin LH to FSH. This will lead to impaired development and maturation, and this will lead to chronic anovulation. So what does clomiphene citrate do for the treatment of PCOS? Clomiphene citrate is a partial agonist at estrogen receptor. As I mentioned, it's an selective estrogen receptor modulator. It binds with high affinity to the estrogen receptors at the hypothalamus. It binds to high affinity to the estrogen receptors at the anterior pituitary, as you can see at the right hand side of the screen, the figure there. You can see clomiphene, and there is a plus in the middle of the arrow. That means it is an agonist. It's a partial agonist to the estrogen receptor, but it is not a full agonist as estrogen does. So that's why it does not have the same effect of estrogen in negative feedback inhibition of FSH and LH. Therefore, clomiphene citrate produces less negative feedback inhibition of FSH and LH, and this will lead to the higher release of FSH and LH, leading to more better maturation of follicular stimulating hormone, and more better maturation of the follicles, and then by the producing the LH surge middle part of the cycle, the LH surge will lead to the ovulation. I hope the mechanism of action of clomiphene citrate as a partial agonist acting on the anterior pituitary is well understood. It's important how it replaces estrogen by binding to the estrogen receptors, but its action is weaker in causing the negative feedback inhibition as compared to estrogen. Estrogen is stronger, so this will lead to less intense negative feedback inhibition, which means a higher release of hormones FSH, LH, gonadotrophin from the anterior pituitary, leading to a better maturation and a higher LH surge, leading to ovulation. So this is the exact mechanism of action. Pharmacokinetically, as the body does to the drug, the body can well absorb clomiphene citrate as it's taken orally. It is a highly lipid soluble agent, and it has a half-life of 5 to 7 days. Usually patients start taking clomiphene citrate by day 4 of menstrual cycle, day 4 after starting the menstrual bleeding, and then it has significant protein binding and enterohepatic circulation, and is then distributed to adipose tissue, and it is excreted primarily in the urine. So what's the benefit, or what's the indication of clomiphene citrate? It is used to stimulate ovulation in women with amenorrhea, oligonorrhea, and ovulatory dysfunction, and in patients suffering from polycystic ovarian syndrome, but it has no value, as I mentioned before, in ovarian failure or cases of pituitary failure. In cases of ovarian failure or pituitary failure, it is of no use. We cannot use the clomiphene citrate. It is ineffective. The dose of clomiphene citrate is 50 milligram to 100 milligram for 5 days. Because it has a long half-life, it leads to a rise in the plasma LH and FSH for several days because of its long half-life. So the rise will be of FSH and LH will happen before the ovulation, and this will help in the maturation and the producing the LH surge. Going to the adverse effects, then we have to know that it is a well-tolerated drug. Most of the side effects are mild and reversible, and some of them resemble the signs or the symptoms that appears in postmenopausal females, where the estrogen level becomes low because it's a partial estrogen agonist, as I mentioned. So it's a weak agonist at the receptors, leading to a feeling of hot flushes, which resembles those of postmenopausal females. Eye symptoms like prolongation of after image, and this can create a problem during driving, especially if a female is driving. This can create a risk of having a traffic accident because there is a prolonged after images. Headache, constipation, and skin allergies, all these are reversible, and also hair loss can happen reversibly. Nausea and vomiting increase nervous tension, depression, fatigue, and breast tenderness. Another weight gain, and the very common uh, problem, or very common, let's say, adverse event, is the presence of multiple pregnancy or twin pregnancy. Twin pregnancy is a common risk, especially in 10% of the cases. 10% of the cases who are using clomiphene citrate. The contraindication is in the presence of liver disease or liver dysfunction, uncontrolled thyroid or adrenal dysfunction, yeah, and then the presence of an ovarian cyst, because the drug itself causes ovarian enlargement. The drug itself, clomiphene citrate, causes ovarian enlargement, so this can can have a risk for those who are already having ovarian cyst. And now the precaution, as I mentioned to you, first is the visual symptoms, the prolongation of after image, which can be risky for those who are driving. The other risk is for prolonged use. If it is used for 1 year or so, then there is a risk of having ovarian cancer as a result of ovarian enlargement side effect. And then uh, therefore it shouldn't be used for more than 6 cycles. Should be stopped after 6 cycles. If there is no use of, or it is not producing any benefit, that means that there is failure of or resistance against clomiphene citrate, and another alternative method of treatment should be uh, taken, should be considered. Um, for the gonadotropin therapy, as I mentioned to you, whenever there is hypogonadotrophic anovulation, which can be easily detected by taking a blood sample in the lab. So we use the injectable preparations which contain FSH or LH, or the combination of both, the combination of FSH and LH. So FSH only, the latest application, the latest way of treatment is to use the FSH follicular stimulating hormone alone, eh, which is either not naturally produced by extraction from the urine of postmenopausal females, and it's called urofolitropin, or it is synthetically synthesized by recombinant DNA technology to produce human FSH, the exact as the in human by recombinant DNA technology, using folitropin. The name is folitropin beta, and all these are giving intramuscularly. Okay, luteinizing hormone can be used in females to stimulate estrogen release from the ovaries. Okay, but it's less commonly used nowadays. FSH analogs are more common to be used as ovarian stimulation inducing agents, ovulation inducing agents. Human chorionic gonadotropin, which has almost identical structure, also is used in place of FSH for the treatment of hypogonadism in men and women. Both men and women can make use of LH for the Leydig cells in the testicles for the men, can help in the further production of sperms, and for female as part of controlled hyperovarian stimulation. The other drugs that can be used is to stimulate the hypothalamic gonadotropin releasing hormones or their analogs. The analog is leuprolide, and leuprolide here is a synthetic analog to the gonadotropin releasing hormone. So whenever it is given to the patient in a pulsatile form, in pulsatile doses, which is similar to that what happens in physiological cycling, in the normal physiology of the body. It appears to be released in a pulsatile form. So in this case, it will stimulate the gonadotropin release, and this is used in the diagnosis and treatment of hypogonadal states in females and also in male patients. But this is mainly used, as I mentioned, to treat hypogonadotrophic anovulation, in which there is a reduction in the production of FSH, LH by the pituitary due to pituitary hypogonadism or due to higher up hypothalamic hypogonadism. But the same leuprolide, if used in steady doses, this is worth mentioning. It is not part of ovulation inducing information, but it's worth mentioning because to complete the picture for leuprolide, if it is given in steady doses, then it causes a marked inhibition. Okay, so pulsatile dose causes stimulation, pulsatile dose of leuprolide causes stimulation, and therefore used for the treatment of hypogonadal state in both males and females. While the same leuprolide, if given in steady doses, it leads to the opposite. It leads to marked inhibition of gonadotropin release, which is considered as a medical castration. And therefore, this can have an implementation or an indication to be used for prostatic carcinoma, where we expect increase in the in the androgenic levels, endometriosis, and in preventing precocious puberty, puberty that's happening earlier than the age of the natural puberty and before age of 11. So a precocious puberty before the age of 10 or 11, it can be treated by steady doses of leuprolide, while the pulsatile doses are used to stimulate the gonadotropin release. Yep. Uh, Hyperprolactinemia, it is important for us to understand the two questions raised here in this slide. First, why do females with hyperprolactinemia complain of anovulatory infertility? And the second question is, why do we use cabergoline to treat females patients with this type of infertility? Of course, these two questions are related. The answer to the first question is actually can be understood from the figure on your right hand side of the screen, where you can see that in hyperprolactinemia there is overproduction of prolactin, and this overproduction of prolactin will lead to a negative, you can see the minus on the right side of prolactin. There is a negative feedback inhibition of gonadotropin release, FSH and LH, and this FSH and LH both are important for ovulation and for spermatogenesis in males. So whenever there is an increase in prolactin in hyperprolactinemia due to any cause, like for example in pituitary adenoma producing prolactin producing tumor causing hyperprolactinemia, it can lead to negative feedback inhibition to gonadotropin, leading to reduction in FSH and LH. So how do we treat? We use cabergoline, or we use bromocriptine. Cabergoline and bromocriptine, both of them are dopamine receptor agonists. And as we can see also from the diagram, that dopamine. Yes, yes. Oh, okay. Which slide are you looking at now? Oh, okay, okay, okay. How about now? Because I'm actually moving the slides in my screen. Still not changing. Okay, is there a problem with sharing? Mhm. Mm,